Hey folks, Scott Weingart here, and this is an MCrit We. I was recently invited over to Glasgow just before the SMAC Dublin conference by my friend Owen Colgan, and right before I spoke was a lecture by Stephen Hearns, the lead for the Glasgow Emergency Medicine Retrieval Service, their helicopter EMS service, and it was just fantastic. My entire time in Glasgow was fantastic. Owen treated me so well, and it was such a joy. If you ever get a chance to visit anywhere in Scotland, highly recommended. And obviously the Scotch, wow. But back to the topic at hand. Stephen Hearns gave an amazing lecture on cognitive offloading. But what I really took from it, and I think it was the thrust of the lecture, was just how you could create a system of excellence. And this is not unique to the Glasgow service. Every major helicopter EMS service I've seen, whether it be the London Trauma Service, the Sydney HEMS service, and countless others whose members I've interacted with, they have really, I think, cornered the market on just taking every piece of optimal care and figuring out the best way to go about it. And it just made me feel really bad that we're not putting the same level of systemization and optimization in place in the resuscitation bays and critical care units that I interact with in the emergency department. So this lecture was inspiring to me to figure out ways to change. Now, it's obviously easier in a helicopter EMS system because all of the personnel you interact with are part of that service. Very similar to my impressions of why I consider Shock Trauma Center to be one of the best hospitals in the world for the care of a sick trauma patient, because there were no tribes, as Vic Brazel would talk about. There are no silos. There's just one service, the Shock Trauma Center service. There's just one service, the ERMS of Glasgow, the Sydney HEMS service. And that's easier because it's not like that in emergency medicine, critical care, or resuscitation. But there must be ways. There must be ways to come closer to what's going to be demonstrated in this lecture. So take a look and then go to the comments section. Tell me what you think. And I'll put Dr. Hearns' Twitter handle in the show notes as well. So if you want to contact him about any of this, then you'll be able to do so. Okay, enough. Let's get to it. Steve Hearns, Cognitive Offloading, Helicopter EMS.
My talk's a wee bit less scientific than Dip's. So, cognitive offloading and critical care retrieval. I was up all night thinking that title up, and I can see you're excited. I can feel the tension in the room. Now, also I was just sitting there and I was just wondering, as Alistair said, other things that are on, and I'm just wondering, if Scott Weingart wasn't here, if there wasn't that free bar there, how many of you really would have paid 25 quid and come out your house on a Saturday night to hear me talking about that? And linked to that as well, I was just sitting there and I was saying to some people earlier on, been the warm-up act for Scott Weingart in the Royal College in Glasgow is a bit like being Susan Boyle as a support act for Bruce Springsteen at Hampden. Sometimes it's tricky trying to come up with the right title for a talk, and maybe this time I didn't get it right. And I think maybe this one is a wee bit more accurate and concise. Now, what I want to talk to you about is the situation that all of us as resuscitationists, as emergency physicians, intensivists, find ourselves in when we're looking after someone who's seriously ill or injured, when the cognitive load upon you becomes too much, when there's too many decisions, too much stimulus, and your ability to look after that patient decreases, and particularly in the demanding retrieval setting. I've only got one graph. This is it. So this is the Yerkes-Dodson curve. Now, what these psychologists found was that up to a certain point, when the decision-making demand upon your brain, when the stimuli, when the stress increase to a certain point, your performance will increase until you reach a point of optimal performance, that sweet spot. And that's partly why we do our job in looking after seriously ill people. We enjoy that when we're looking after someone seriously unwell and we reach that point. However, it's all too easy for the number of stimuli and stresses and decisions to increase to the point where we start moving to the right side of this curve and our performance decreases and our patients don't get the best care. Now, if I give you the situation of a 50-year-old woman in an emergency department or an intensive care unit with pneumonia, respiratory failure, septic shock, you would probably all be at the peak of that curve. 2 or 3 doctors, a couple of nurses in there resuscitating that patient. Now, if I gave you the same patient on a couch in a doctor's surgery in the tiny island of Jura, in a setting with absolutely no laboratories, no radiology, and you're going out there as a team of 2, then you're going to move a wee bit over to the right. Now, if I told you that you'd found out that the weather was too bad to fly there in a helicopter and you were going to have to go out there in a lifeboat, intubate that patient, start them in a vasoactive drug, and then bring them back on the floor of the lifeboat, most of you would be quite far over to the right of that curve. Similarly, if I give you a patient in your emergency department, a paraglider who was 30, who had piled into a 500-foot cliff on Arran, had broken their lumbar spine and had some cord compromise, you would be quite over to the left here. That really wouldn't tax you. But if I let you know that that patient was actually still halfway up that cliff and you'd flown out there in one helicopter, getting put in another one, and every time the helicopter went near them to try and winch them off, their chute filled with air and they were going to be blown off the cliff, and you had to be lowered down from the top of the cliff to assess that patient, give them analgesia, put them in a stretcher and cut off their parachute with a knife before being winched into the helicopter. I think most of us would be quite far over on the right of the curve and would be quite dysfunctional. So what I want to talk to you about is what we do in the Emergency Medical Retrieval Service and the systems that we have put in place over the 12 years that we've been in existence through experience. Now, for emergency physicians and intensivists, it's quite easy to understand how we could become cognitively overloaded, demands a number of patients and the complexities, etc. It's a wee bit more hard to imagine for the anaesthetists in there amongst you. One patient at a time, ASA 1 patient on the table, acoustic neuroma, 8 hours, SD7 with you. What's the drama? You've had a whole programmed activity of pre-op assessment to work out what you're going to do with the guy. You've spent that 4 hours and decided, I'm going to give him some atracurium and some propofol. But you can become overloaded in those situations, even with one patient. Gets to about 9:30, you're getting bored, and you go for a coffee, and you're in that coffee room, and you're sitting there, and bang! Your whole day is absolutely turned upside down. The cognitive burden on you, the decision-making burden on you is absolutely immense. Yes, someone's brought in a selection of biscuits. So, all retrievals are generally unpredictable, but they're made up of predictable components. So the way that we deal with this is by planning and practicing the predictable. And if we get that right, then it makes the unpredictable possible and safe. We as individuals and as a service need to constantly reflect and learn from our experience and proactively change our procedures and how we behave. We need to put lots of information together, but it needs to be accessible to people in the retrieval environment. Our systems and our governance have been inspired by 2 people. This is Gareth Davis, who's the medical director of the London Trauma Helicopter, where I finished my training. 10 years of training, Australia, Aberdeen, Glasgow, and knew absolutely hee-haw about clinical governance and safety. Gareth Davis says that the best performing units in the world deliver clinical excellence, not because they provide unique treatments or have access to highly technical equipment, but because they deliver the most basic care in a quality assured manner with exquisite attention to detail. The next person who certainly inspires me and inspires our service is this baldy guy in the car, Sir David Brailsford, who is the lead of the British Sky cycling team. And what he talks about are marginal gains, the idea of putting time and resource into every component which can affect performance. So even something that can improve performance by 0.1%, 0.2%, if you put all that effort in and add that together, that's how you win the Tour de France. And he's had 2 British Tour de France winners. The Tour de France isn't won on the 20th of July in the Champs-Élysées. It's won on the 20th of December when the mechanics are deciding what bearings to put in the time trial wheel set. It's won on the 20th of January when the chef and the nutritionist decide how they're going to get 6,000 calories into each of those riders for 3 weeks. And it's won on the 20th of February when the sports scientist is downloading all the power meter data from the training camp in Forteventura. Here's someone else who's won the Tour de France a couple of times. He's not actually inspired us, sorry about that, Scott. I really like this sign up from the library in Australia. Basically, they've moved all of his autobiographies into the fiction section. So what we really want when we've got a critically ill or injured patient is to have all of that brain capacity, all of that bandwidth, all of that cognitive ability to look after the patient. That's reasonably okay in a hospital, but in a pre-hospital and retrieval setting, that's much more difficult. Quite a bit of our cognitive function is taken up by information recall, lots of things that we need to remember in the out-of-hospital environment that we don't need to know about in a hospital. Our service retrieves patients from 25 different rural healthcare facilities. They're all different. Some have got consultants in them, some don't. Some have got CT scanners and most don't. Some have got blood. Some you go by helicopter, some you go by plane. And we've got 8 different receiving intensive care units and emergency departments. I can't retain all of that information in my head. We use multiple different transport platforms, often 2 or 3 on the one retrieval. Often in a team of 2 or 3, we might have to undertake some interventions that we only undertake once a year, once every 5 years. Working at Berryplex, putting down a Seng stacking tube, anaesthetising a 7-year-old child in the street. Lots of information that we need to have in our head in a time-critical environment. Thinking about equipment as well. Basically, if you've not brought it, you've not got it. You go out into the pre-hospital environment and you want to undertake a critical care intervention, you need to have all of that equipment with you. You don't want to be thinking about whether you've brought it or not. And that's the same if you go to a small rural hospital. If you want to anaesthetise that patient, you need to be equipped for things that can go wrong when you're there as well. And we need to be cognizant of the fact that we need to carry that in an aircraft. Weight issues, space issues, and compatibility with avionics. And we need to make sure it's safe and secure in the aircraft as well. You'd also think about the team that are with you. In a hospital, that really isn't an issue. There are lots of people that can come and help you make decisions, specialists help you assess the patient and carry out interventions. 50% of the time, the emergency medical retrieval service deploys as a team of 2, a consultant and a critical care practitioner, or a consultant and a registrar. That's a lot of decision making, a lot of interventions, a lot of communication for 2 people. If we go to pre-hospital scenes, absolutely paramedics there, bending over backwards to help us. But when it comes to the more advanced interventions, they've got no experience of that. And when it comes to the more advanced things that we do, often there's not a lot that they can do to help us. You need to be thinking about transport as well. Well recognised it's hazardous transferring seriously ill patients even in a land ambulance, much more so in an aircraft where we can't assess the patient, recognise deterioration or do anything about it. And that's even in a specialised aircraft which is designed for aeromedical transfer. A lot harder even in a military or search and rescue aircraft, which has really got quite a more utilitarian fit inside. Extend that even further to situations where the patient's in a position where you can't actually land the aircraft. and thinking about the dangers of flying in bad weather in Scotland and the challenges of that, especially in the winter and at night. And also the demands of coordination. This is absolutely the Achilles heel of retrieval in Scotland. Trying to get hold of air assets, trying to coordinate it, getting the team back is an absolute pain in the ass. It really is. And it's actually often the duty clinical team that will be doing that. It's not unknown for 10 phone calls to be needed to be made to coordinate that. That takes a lot of brain power away from looking after the patient. And finally, thinking about risk as well, the risk of working in that aviation, in that pre-hospital environment. That's what a seagull can do to an EC-135 helicopter at 150 knots. You need to make sure that your equipment in the aircraft that's supplied to you is actually secure and that you're in the right type of aircraft. And if you enter turbulence, or worse still, if you crash, that equipment is not going to kill you. And it's not just the dangers of flying in Scotland as well. Also the difficulties and the dangers of working in the pre-hospital environment. That's the sight that you see from the aircraft when you see that car hanging over there. And you're thinking of the risks of that. This guy down here, though, I think he was probably off sick when they did the dynamic risk assessment course at work. So someone in that car, compromised airway, chest injury, you're going to get into that car, what are you going to do? How are you going to balance up the risks of that? And also not just the physical risk maybe of climbing that ladder to go onto the roof of that building, which is potentially unstable, fire risk from fuel, asbestos, but also the psychological potential risk that you could put yourself at with the things that you're going to see in some of these environments. And also just the risks of fatigue and cold. The guys are actually just away to Shetland at the moment. That's a 14-hour overnight job involving sometimes being on the tarmac in Sunborough at 2 o'clock in the morning. So all of those demands upon our brain and things that we are thinking about before we even get anywhere near thinking and treating that patient. Very easy to see without safe systems and governance how we could end up on the right side of the curve and not giving the best treatment to the patient in the pre-hospital and retrieval environment. So what do we do about that? Well, as I said, we plan and we practice the predictable, and we learn from experience over 12 years. So I don't really need to memorise all of that information that I went through earlier on. All of that is written down in 140 standard operating procedures that are completely bespoke for our retrieval service, that are bespoke to the transport platforms we go on, the drugs and equipment that we use, and our experience over that time. And they're all stored on an iPhone, iPad app designed by Dave McKean from Edinburgh. So that I can actually, when you start with our service, this is the manual that you read to understand how we operate. I can actually read that in the aircraft or when I'm with a patient. And it's important to make all of that information accessible. This is 2007, before the app. Also in the app, we've got location guides for every single centre that we visit, all the direct dial phone numbers of the wards, where the landing sites are, how far it is to travel to the hospital, and do they have blood for transfusion? Do they have access to x-rays? We've also got calculators. How much oxygen do we really need to safely carry for this patient during this transfer? Beriplex calculators. And for the 7-year-old kid, how much ketamine do I need to give that child to put them off to sleep? All of that has been accumulated through 12 years of experience in a huge database of every patient that we've retrieved. Every drug, every blood pressure is in that database. And we've moved on now over the next few months to we've commissioned an IT company to digitise that so that we'll be able to put our information in an iPad mini when we're actually doing the retrieval, and that will go straight into the database. Putting a lot of information together, we've got about 20 key performance indicators. And using the database, we can see how well we are performing compared to those performance indicators. And if we're not meeting our own targets, then we can adjust how we operate and adjust our standard operating procedures. It's also really important to learn from significant events when things don't go that well. So again, we've got our own significant event reporting system, which is online, called Sphere. Again, designed by a couple of guys in the service, Chris Multy and Scott Hepburn. And we can report incidents in under a minute using an iPhone actually in flight. A wee bit different from Datex. I've Datexed you. And that allows us to have a really low threshold for incident reporting so that we learn from that and again change our systems. A lot as well with regard to peer review. So if I retrieved someone today, another consultant would look at my clinical record tomorrow, review that. He would phone up the receiving unit, find out about the patient, ask for feedback from them. He phones up the referring unit, gives feedback about the patient, and asks for feedback about me as well. 3 times a week, if the guys are not out, we've got scheduled time for case-based discussions with peer review. And all of our patients are followed up using the SICS database and the trauma audit group database as well. And if we've got cases with particular learning points, then we will discuss them at length as a longitudinal audit at our clinical governance meeting. And we're quite transparent about that. We actually open that up to anyone who wants to come along, and we open up a video conference to our remote service users. It's also important, retrieval medicine is a new specialty, and it's quite a small specialty, so it's important that we learn from other high-performing retrieval services throughout the world. And we've got excellent relationships with guys from all of these services. And we learn from them and learn from their experience. We started our own conference, we've just run the 10th one, the UK Retrieval Conference. Alistair's our lead for research, very active research programme, and contribute to international research collaborations. Now I'm just thinking actually we've got someone from out of town. Scott, are you familiar with Twitter? Don't know if, has it maybe reached America yet? Well, try and get onto that. There's some really good stuff. You get some good links to podcasts and stuff like that. You can maybe get yourself up to speed on some stuff. But remember, you heard it first here in Glasgow. Checklists as well for cognitive offloading. When you've got multi-stage tasks that might be quite high risk when your head's somewhere else, even just giving a blood transfusion, that can make the whole process safe and calm. Cognitive aids for things that you do infrequently and are not intuitive. I can never remember when we're driving in blue lights how to change the talk group in the ambulance service airwave radio, but I can just fire that up in the app and it tells me what to do. Multiple casualty major incidents. That is the time, certainly in my experience, when you become massively cognitively overloaded, psychologically, emotionally, physically. And this is the bus incident that the rest will be thankful over the winter, which we attended. Again, the app has got individual action cards for each individual person, gives their role and makes the whole thing work without people having to actively think about what they've got to do. Thinking about equipment now, making sure that you've got the right equipment for the job, like this blood cool box which was developed in Afghanistan so we can carry blood for pre-hospital transfusion. Handheld ultrasound machines, handheld iStat near-patient testing machinery, compact blood warmers that we can actually carry in the aircraft and use in our environment. Thinking about resilience, what do we do to keep that patient safe if the monitor fails, if we run out of oxygen, we run out of power? And having really robust equipment management systems to make sure that bags are sealed, 2-person check-in response. I showed this slide earlier, a lot about labelling and stuff, and just to point out that we don't actually put labels on our helmets saying helmet. That's actually the company. I think that's actually quite narrow-minded of them and really not ambitious, because it kind of limits them from expanding into other areas. But that takes a lot of work. This is our medical pack checklist version 31. Film and Roll will tell you 30 times that's been revised since 2004. The other thing we started doing, stealing some wee ideas from 3RU in Edinburgh, is one of the, obviously the most hazardous and complex things we do is pre-hospital anaesthesia and anaesthesia in small community hospitals. So we now film ourselves doing that. The consultant, CCP or Reg, will carry a badge camera and film us doing the emergency anaesthetic. I just want to show you one of that. So we can't actually show footage from live jobs. Ethically, we're not allowed to do that, but this is what we see with the badge camera from a simulation.
360-degree access, check. Monitoring, BPSB2 ECG visible, check. I can see. IV access ×2, working, connected to fluid, runs intellect. Check, running well. Pre-oxygenation, ongoing with the trauma equipment. 2 oxygen cylinders. Suction check, right side of patient, check. ET tube ×2. ET cursor check and moved. Check. 20 mil syringe. Check. 2 working laryngoscopes. Check. Tube tie. Check. Roger, check. Catheter mount filter, end-time CO2 attached to the monitor. Check. LMA, surgical MOA inside. Check. Drugs, induction agent.
So, what we can do with that is we can come back and we can reflect how well did we communicate with each other, how well did we communicate with the paramedics that were on scene, how well did we utilise that resource. Also, what we want to do with that process in the checklist is A, calm things down before we actually put the patient off to sleep and attempt the intubation. And the way that all of that equipment was laid out there is absolutely standard. Every time we do that, every CCP will lay that equipment out exactly the same way, trying to normalise deviance, and that's quite hard with 28 consultants. What we've learnt from that is we've timed certain things, and getting the equipment together was really quite time consuming because we didn't organise the equipment properly. So 2 guys, Paul Swinton and Neil Sinclair, have designed a bespoke airway bag. Basically, you open that bag and everything you need is right there. So very little room for error, very little time wasted. And also, drawing up anaesthetic drugs was taking us 8 minutes on scene and tying up one of the most experienced members of the team. So now carry pre-filled syringes. So thinking about the team as well, you need to have the right wingman. I only found out when I was looking at this photograph the other day, he ended up being Dr. Green in ER. I didn't know that. So we need our team of advanced critical care practitioners. We've now got 8 of these guys, nurses and paramedics that work full-time with the retrieval service. Absolutely the backbone of the service. Those guys are completing an MSc in critical care retrieval that we've established with Glasgow Caledonian University, and also they sit the diploma in retrieval and transfer medicine, the only postgraduate diploma in retrieval medicine in Europe, which we run at the Royal College in Edinburgh. Also get 2 trainees at any one time, and pre-hospital emergency medicine is now a subspecialty, and we've now got training approval to deliver that subspecialty training. We start every day after kit checks and 3 briefings with simulation and drills to make sure that that team gel for the day when they actually go out to do these types of things for real. Team resource management and human factors are also really imperative to us, and it's mandatory for every member of the team to undergo a full day of human factors and TRM training with an external provider every year. Half the time we also work with the paramedics from the air ambulance helicopter and the air ambulance plane, and it's imperative for patient safety and for efficiency that those guys muck in as much as possible, getting involved, setting up infusions, setting up invasive pressure monitoring, etc. And we've developed, along with them, a set of competencies for primary and secondary missions. Also, the rural doctors and nurses, they need to know what we'll expect when we get there and how to help us to optimise patient safety. So each rural centre has been designated a liaison consultant, And that consultant, CCP and a registrar go out once a year to provide training and feedback. And we use this is a mobile skills bus on one of the islands, and this is what it's like inside, so we can actually set up simulation wherever we are. Transport. So we are at last getting a clinical coordination system, and that's going to take the burden into ambulance control and away from the actual team doing the job. We're extremely lucky that we have moved to a new bespoke retrieval base alongside the helicopter and the plane at Glasgow Airport and our paediatric and neonatal colleagues, which means access and joint working with the pilots is a lot easier. We need to make sure that none of the cognitive function of our team is actually taken up by getting on a helicopter. If a 10-ton Sea King helicopter landed in Blythswood Square just now and you got on it, 90% of your bandwidth would be thinking about being on that helicopter, not about the patient. So we need to make sure that our guys know exactly what's happening on that aircraft so that they are happy and comfortable to work in that environment. And we need to think about risk so that cognitive burden's lost as well. Have good systems for balancing risk against benefit. 3 o'clock in the morning, the weather's terrible, you need to go in a search and rescue aircraft. Do you really need to go for that patient? You need to give people the right personal protective equipment to be safe and feel safe in the pre-hospital environment and in the aviation setting. You need to give them good communications, and you need to give them state-of-the-art things like personal locator beacons so that you can be found if the aircraft goes down. A wee bit academic if you're in the search and rescue aircraft anyway, but that's another. And things like short-term air supply so that you can actually breathe for a couple of minutes underwater, try and get you out the aircraft. And have the systems in place that people know how to behave safely and know how to use that equipment. And train them, helicopter underwater escape training and using the survival equipment. And you need to have immersive simulation, putting our guys in that situation, major incident simulation and RTC simulation. And finally, you need to think about when bad things do happen, what way can you support people psychologically? We use the Royal Navy's trauma risk management system, which was hugely beneficial to us after Clutha, and have the right level of insurance. The normal NHS level insurance isn't really good enough to have a bespoke insurance policy. So ultimately what we're wanting to do with all of these systems is to take the thought that's required about all of those things away so that you've got as much of your cognitive capacity left to think about assessing and treating that patient to the best of your ability. Scott, ubiquitous chip, I missed lunch today, but just to say, Clydebank Shopping Centre, breakfast on me tomorrow, mate. Thank you.
Okay, thanks very much, Steve. Excellent talk. We have a couple of minutes for questions. If anyone, I don't know if we can put the lights back up, perhaps. Anybody got any questions they want to ask? Good. Okay, I'm going to ask questions. So, most of us work in a hospital environment here, not in pre-hospital and retrieval medicine. So, what do you think, if there's one or two sort of key lessons for us that work in hospitals, what do you think they are?
It's very, it's not easy. It's difficult to do all this, but it's much easier because we've got the resource, we've got the type of people that we have recruited that have got the right attitudes to all of this. We've got the right resources, and we've got a relatively small number of patients. We've only got 1,000 patient contacts a year. Extrapolating that to an emergency department with huge staff turnover that sees 80,000 patients a year is difficult, but the principles to me are the same. Genuinely about planning how your department treats a certain thing, how that interacts with other specialties, and actually writing that down in a format that's easily acceptable. So actually not calling them standard operating procedures, but having that type of process, I think, can be hugely beneficial, and trying to make time for reflective practice, which I think is difficult.
Okay, so if you want to join me in thanking both our speakers from this session.